Hello, and thank you for joining us for Coping with Digestive Problems, the second in the Lung Cancer Alliance Coping webinar series, designed to educate and provide practical ways to manage the most common symptoms and side effects experienced by lung cancer patients and survivors. Hang on one second. Sorry, we're just having a little, there we go. I'm Maureen Rigney, a social worker and Director of Support Initiatives at Lung Cancer Alliance, a national nonprofit organization based in Washington, D.C., and dedicated to saving lives and advancing research through empowering those living with or at risk for lung cancer. We have a whole host of programs and services designed to improve care and quality of life for the lung cancer community. For more information, please visit our website, or you can just contact me directly. In a recent survey of over 800 lung cancer patients, survivors, and loved ones, we learned that digestive problems, including nausea and vomiting, constipation, and diarrhea, are among the most problematic treatment side effects facing those with lung cancer. Today, two experts will help us learn how to prevent and manage those issues. We'd first like to recognize our program sponsors, Helsinn and Tesaro. Without them, the Coping series would not be possible. Thank you. It's now my great honor to introduce our experts. Niki Koesel has practiced in palliative and hospice nursing since 2003 and as an advanced practice palliative care nurse since 2005. She's board certified in advanced practice hospice and palliative nursing. She's currently the Director of Palliative Care for Carolina's healthcare system and is responsible for 9 inpatient consulting teams and 4 outpatient clinics. She's currently pursuing her doctorate of nursing practice at Duke University. In 2010, she was awarded the Advanced Practice and Palliative Nurse of the Year and continues to work closely with her local and national hospice and palliative nurses association. As an oncologist and palliative medicine physician, Dr. Eric Roeland is committed to discovering and developing effective solutions for improving the quality of care for cancer patients with advanced disease. He is uniquely positioned as a faculty member at the UC San Diego Moores Cancer Center, a National Cancer Institute designated comprehensive cancer center, where he directs the only outpatient palliative medicine clinic with an embedded clinical trial program in the region. He is committed to building symptom intervention, evidence-based clinical practices, and promoting rigorous scientific validation of novel approaches. His current research primarily focuses on cancer symptom intervention clinical trials. So here's an overview of today's agenda. Niki will kick us off with a brief overview. Then Dr. Roeland will help us understand, prevent, and manage treatment-associated nausea and vomiting. Niki will then help us tackle constipation, followed again by Dr. Roeland on the management of diarrhea. We will have time at the end for your questions. Please note them in the area to the right of your screen where you can type them in, and just feel free to do that as they come to you during our presentations today. So now we're going to start with Niki, and take it away, Niki.
Okay. Good afternoon, everyone. It is my pleasure to be with you today to talk about these very common concerns for those with lung cancer. So throughout the next hour, we're going to hit a few different foci around digestive issues when you or someone you care about is dealing with lung cancer. So why does this happen? We really want to talk about what causes nausea, vomiting, constipation, or diarrhea. We'll talk more about this being caused by underlying diagnoses, chemotherapy, different medications, common electrolyte changes that people go through once they're undergoing treatment for cancer. And how common does this occur? There are multiple studies out there that quote a variety of statistics, but essentially 70 to 80% of patients experience some type of digestive issues when they're going through chemotherapy for cancer. Around 25 to 60%, so a very fairly wide range do experience nausea throughout their course, and around 50 to 75% also experience constipation. We'll also talk about the association of diarrhea, primarily related to different chemotherapy agents or immunotherapies that are used in the setting of lung cancer. And so we also feel that it's very important that we talk about how this can impact your medical treatment and course and your quality of life. So we really want to emphasize today the importance of you identifying these problems as early as possible, if not preventing them, and then trying to empower you to truly talk about this and feel comfortable talking about this with your medical team. As medical providers, we're very aware that the impact of any type of digestive issues in this setting has a significant impact on physical, emotional, and even social areas around quality of life. So I'm going to turn it over now to Dr. Roeland to kick us off learning more about nausea and vomiting in this setting.
Great. Thank you very much. Greetings from San Diego. So moving ahead here. I don't know if I have control of the screen here.
Yep, you do. But we can advance to the next one there if that's helpful. There you go.
So today we're going to be covering nausea and vomiting, the risk factors associated with it, how we can treat it, specifically mentioning chemotherapy-induced nausea and vomiting, and then I want to introduce you to a very new and important drug in this setting. So the basics are that despite 5 antiemetic classes, up to 70% of cancer patients experience nausea and vomiting, and it's the #1 side effect that everyone's worried about for patients who are undergoing chemotherapy and or radiation. There's a great debate amongst all my patients of what is worst, nausea or vomiting, and I would express that nausea, even chronic or low-grade nausea, is much worse than the actual experience of vomiting. But both are important to treat and prevent. Prevention is really the key. Sorry, guys, we're having technical difficulties here. Can we advance the next slide, please?
Absolutely.
So with regard to the neurotransmitters that are really involved in nausea and vomiting, I've highlighted several, but the ones in the black boxes are the ones most important when we think about chemotherapy-induced nausea and vomiting. Those include dopamine, serotonin, and substance P. But other neurotransmitters involved in nausea and vomiting include histamine, endorphins, GABA, cannabinoids, and acetylcholine. And just so everyone understands, we really think about 2 areas in the body that are responsible for nausea and vomiting. One is the brainstem, and the reason why everything we focus on the brainstem is this is a coordinated response, and you don't want to actually have to think about vomiting. So the brainstem coordinates and senses this experience and coordinates that with the gut. So when we're thinking about brainstem, we think about the emetic center located in the area postrema of the brainstem, and primarily I think of dopamine and substance P when I'm thinking about the brainstem. And then in the gut, we're thinking more about serotonin. And there's multiple risk factors for patients, and it's important for you to understand these risk factors and let your clinicians know if you have these risk factors. So by far, the most important risk factor is if you have experienced nausea and vomiting with prior chemotherapy, you are 4 times higher to experience nausea and vomiting with more chemotherapy. So be sure to let your oncologist know this. Additionally, women who are less than 50 years of age who do not drink a lot of alcohol are at higher risk of developing nausea and vomiting. This is the one time where people who have higher alcohol intake actually are protected. People who are anxious or have a history of nausea and vomiting associated with pregnancy or motion sickness all place you at higher risk of developing these symptoms with chemotherapy. So I'd like to consider an approach to nausea and vomiting that's very similar to blood pressure. What I mean by that, if you can advance the next slide, when you have blood pressure that is out of control, you're started on one agent, highlighted here as target number 1. That agent then is used to a maximum dose, and then if your blood pressure is still not controlled, we add a second agent with a different mechanism of action, highlighted here as target 2, and so on and so forth. So it's an additive approach where you try to maximize the effect of one drug, and if that doesn't work, you add another drug, which is in direct contrast to just trying multiple drugs at varying time points, which is what I frequently observe by many of my colleagues. And this is not a comprehensive list, but important reference for those people that do have particular concerns about nausea and vomiting. I've separated them into classes. So we have the serotonin, the 5-HT3 receptor antagonist, the NK1 receptor antagonist, dopamine receptor antagonist, benzodiazepines, cannabinoids, glucocorticoids, and then this new drug I'm going to tell you about, olanzapine. Many of these you receive by vein or through your port before actually receiving chemotherapy. The most common ones given include ondansetron, ondansetron or Zofran, and then palinosetron or Aloxi. And the common side effects associated with this class of medication include constipation and headache. So when you get these medications prior to chemotherapy, many patients are surprised that they actually get constipated around that time. And that is, has to do with these drugs in particular. The other drug that works on substance P is Amend, which is available as an oral or IV agent, a prepitant or phosphoprepitant. This is again something that you receive prior to chemotherapy for people at high risk of developing nausea and vomiting, with very little side effects except for some drug-drug interactions. And for those of you on clinical trial, it may affect what they call the QTc interval, which is measured on the EKG. Additional drugs very frequently used are dopamine receptor antagonists, and I've highlighted some of the key side effects. Reglan actually causes stimulation at the stomach and therefore can cause diarrhea. But if you're experiencing constipation around chemotherapy, this is one of my favorite antiemetics for that reason. Phenergan or promethazine causes sedation, and anecdotally, patients report that compazine or prochlorperazine also causes sedation, although the data doesn't necessarily support that. Other drugs include Ativan, which is used primarily for anticipatory nausea, which we will describe, and cannabinoids. Both of these can cause sedation and confusion. Steroids or glucocorticoids have many side effects, but because of their efficacy in controlling nausea and vomiting, are frequently used in a cocktail that you receive prior to chemotherapy. And then this last drug, olanzapine, I'm describing the detail later. So why do we care? Everyone listening probably recognizes that nausea and vomiting can interfere with your ability to receive full dose and doses on time. And it causes unplanned office visits, need to go to the infusion center for hydration, emergency room, and even hospitalization. And again, remember that if you experience chemotherapy-induced nausea and vomiting in the first cycle of chemotherapy, you're 4 times more likely to have that experience in subsequent cycles and need to let your treating team know. So prevention is key, and I want to introduce just some basics around how we think about prevention. The first is the word emetogenic. It just means that a drug can cause primarily vomiting. And we separate chemotherapy into 3 broad classes: highly emetogenic with a greater than 90% risk, moderate emetogenic chemotherapy with a 30 to 90% risk, and low emetogenic chemotherapy with a 10 to 30% risk. If you are receiving highly emetogenic chemotherapy, you get a cocktail of 3 drugs, usually aloxi, amend, and dexamethasone, before even receiving chemotherapy, with a goal to avoid the experience altogether. With moderate emetogenic chemotherapy, you get double therapy, which usually includes aloxi and amend, but may or may not include dexamethasone. And lastly, we have low emetogenic chemotherapy, which is many of our new agents in lung cancer with a lower risk, which we frequently just give as needed medication. So when we're thinking about IV chemotherapy, the 2 classic drugs associated with highly emetogenic chemotherapy are carboplatin and cisplatin, or the platinum agents. Again, you would receive triple therapy, including a 5-HT3 receptor antagonist, an NK1 receptor antagonist, and a steroid prior to receiving highly emetogenic chemotherapy. We're skipping moderate here and talking about low emetogenic chemotherapy with a 10 to 30% risk, and you can see the agents listed here, and then minimal at the bottom with less than 10% risk, including some of our newer agents. When we think about oral chemotherapy, we've noted here for you moderate to high, which includes some of our newer drugs, including crizotinib, and low emetogenic chemotherapy, which includes our immunotherapeutic agents, along with some of our newer targeted agents, including Tarceva. So it's very, very important for everyone to recognize that your treating team may not understand that you have symptoms out of control. In fact, we've studied this, and a colleague, Steve Grunberg, out of Toronto, was able to demonstrate the difference between healthcare professionals, which are highlighted in blue, and patients when they're experiencing nausea and vomiting associated with moderate emetogenic chemotherapy on the left and highly emetogenic chemotherapy on the right. And you can see there's quite a discrepancy, especially in the delayed phase, where patients and caregivers are at home and no longer in the infusion center. And because of the media, movies, which demonstrate that having nausea and vomiting after chemotherapy is a normal experience, I think that patients are unlikely to call their team and let them know. That is not the case anymore. And with all the drugs that we have available and approaches, I want you guys to call your providers and let them know what is going on so we can be more effective at treating this symptom. We generally classify nausea and vomiting that is experienced after chemotherapy into 4 different classes. Acute, usually within less than 24 hours, delayed after your first day up to 7 days thereafter. Many people listening probably have experienced anticipatory nausea and vomiting, This is actually an experience where even just driving into the cancer center, having a certain smell, laying down for a CT scan can trigger this experience of nausea and vomiting. And if you have a symptom like anticipatory nausea and vomiting, our recommended drug of choice is a benzodiazepine, specifically lorazepam, also called Ativan, which you would take prior to your trigger. And then breakthrough occurs despite prophylaxis and is better described in the next slide. So you can see acute in the less than 24-hour period, delayed in the 24-hour period is 7 days. And then if you experience nausea and vomiting during that delayed phase, that is called breakthrough, which requires us to use your breakthrough medication. Usually Reglan or Compazine is what most institutions provide. And again, if you have even the slightest feeling of nausea during that time, I recommend that you get ahead of your nausea by taking that breakthrough medication. If that doesn't work, then we have another class called refractory nausea and vomiting, which is currently an area of study. So this is, if you guys remember one thing from today, I hope that you remember this drug. It's called olanzapine. Its trade name is Zyprexa. And it is, historically, it's been used as an antipsychotic for the treatment of schizophrenia and bipolar disorder. And I know you guys aren't crazy, and that's not why we're using this drug. Do not be afraid of its indication. What we have found is that at much lower doses over much shorter periods of time, it is very effective in treating nausea. It is what I call a promiscuous drug, which my trainees seem to remember, in that it hits multiple serotonin and dopamine receptors, which I've listed here. And it's in this promiscuity that it's so effective. So we typically give 5 to 10 milligrams of this drug on the night before chemotherapy and then 4 nights after receiving chemotherapy. A major advantage is that it only takes 1 dose per day, and it's also sedating. So patients who are anxious about experiencing nausea and vomiting or having a hard time sleeping, given the steroids that are also given to prevent nausea and vomiting, this is an excellent tool. The sedation, most patients say that it's worse on the 2nd day of using olanzapine. But in general, as you're taking it before bed, is a welcome side effect. And in fact, this information is so exciting and so promising that it was actually described in a recent article in the New England Journal of Medicine describing how well it actually works. Other tips outside of medication, you got to stay hydrated, which of course is hard when you're feeling very nauseous. Everyone's always asking about which foods and what type of food to be eating. And my rule is actually quite simple. If you're able to look at something and it looks good and you're able to keep it down, to go for it. Very restrictive diets or diets high in fruit and vegetables, oftentimes around this time period can actually cause nausea. So you're just really doing the best you can. Wear clothing that's loose-fitting. Be aware of your triggers, especially strong odors. And that might even be some of your favorite odors before, such as onion or garlic that's cooking in the kitchen. That might now set you off. And then try some relaxation techniques, including distraction or music, just to get your mind off of nausea. So in summary, we described the basics regarding the pathophysiology of nausea and vomiting. remembering the brainstem and the gut. We classify chemotherapy into high, moderate, and low emetogenic classes. And then we have pre-medication strategies based on which class of chemotherapy you're receiving. There is new and emerging data regarding individual patient risk factors, which we described as young females who don't drink a lot of alcohol, have a history of motion sickness, or pregnancy, nausea and vomiting with pregnancy. If you have those personal risk factors, you need to let your oncologist know, because we may end up adding more medications, even if you're getting a chemotherapy class, which would be considered lower. So prevention is key in that we know patients who experience chemotherapy-induced nausea and vomiting are at 4 times the risk of having this experience with subsequent cycles. Remember that blood pressure model, in that you start one drug. If that doesn't work, you add an additional drug with a different mechanism of action. And then don't be afraid of this very important and very effective drug called olanzapine or Zyprexa. So I will pass things over to Niki, who's going to describe management of constipation.
Thank you, Dr. Roeland. We're going to spend a few minutes talking about kind of the other end of the spectrum and talk about dealing with constipation in this setting. I think it's important to always really define what we're talking about, because it can mean something different to many people. And I know not everyone makes a habit of talking about their bowel patterns and bowel movements or GI function, but it is an extremely important topic for you, so I think it's important that we all are talking about the same situation. So the true definition of constipation is that it surrounds the frequency and or any alteration in quality of the stool related to a bowel movement. So this can be that you change how often you're going to the bathroom, or it can be that the pattern or the quality of that bowel movement has changed from being something that's very easy and comfortable to something that's very uncomfortable due to hardening of the stool. So what we look at for more of a technical definition is that 2 or more of the following characteristics occur for you at least a quarter of the time. So that can be that you require straining to move your bowels, that the stool has become hardened. Sometimes people will move their bowels, but then say they feel like they still need to go, and they don't feel like they can completely evacuate the bowels. There can also be a physical feeling or sensation of a blockage, that something is just not moving. And then, unfortunately, I often hear from my patients that when they can't go, they become so uncomfortable that they manually try to remove their stools, which can lead to many, many other problems. And then also, one of kind of the triggers for me is when I ask people, how often do they go in the week? And if they go less than 3 times per week, that definitely warrants more of a conversation. So when you think about the problem of constipation, why in this setting, if you're dealing with lung cancer, would this occur? There are a few reasons. Primarily, it would be related to treatment or medication. As you'll hear later, most of the time, constipation is not associated with chemotherapies. There may be issues with diarrhea or nausea and vomiting, as described earlier, but there's one type of chemotherapy, the vinca alkaloids, that are noted to have some associated constipation, but only in around the 30 to 40% of patients. Many times people that undergo any kind of surgical procedures, a resection, something of that nature, they obviously require anesthesia, which does slow down the bowels significantly. So trying to make sure that we, again, are preventing that problem and staying ahead of it post-procedure or surgery. One of the main reasons that I treat constipation in my palliative care clinic is around the use of opiates or pain medications. Constipation is one of those side effects with opiates that really never goes away. There are other side effects associated with opiates that tend to get better the longer you take the medication. Constipation doesn't work for constipation. So that is a very common hand-in-hand symptom, and we'll talk a little in a few minutes about how to prevent that and treat that. There are several antidepressants that we use in this situation that also lead to constipation, decreased urination, things like that. As mentioned earlier, one of the anti-nausea medications that is very commonly used, ondansetron, constipation is one of the typical side effects. So if you are on that antiemetic and not on an opiate, and you experience constipation, my treatment preference would be to rotate the antiemetic first before adding a treatment for constipation. So it's just important that when you're on medications and you start to experience these symptoms, regardless of why you think they may be happening, that you let your medical team know so that they can really help you come up with the root cause. Also, electrolyte imbalances may occur anytime there's a situation with dehydration or decreased fluid intake. That leads to a decreased bowel pattern and the changing of the stool pattern. Elevated calcium or hypercalcemia can occur with anyone who's got any kind of bone disease process, metastatic deposits to the bone. This can occur. So that's something that we watch in typical laboratory studies, but that can also lead to constipation. And then decreased mobility. Some people think that it's just if you're completely bedridden that this may lead to a slowing of gut function, but actually if there's any real decrease in physical function at all, we can see that affect GI function significantly. And so how does this affect you? What is really the impact? So why are we taking the time today to really talk about this? Because there are obviously very significant physical impacts. So I have patients tell me that when my bowels are not moving, I feel bad all over. I feel nauseated. I feel like I can't eat. My abdomen hurts. My back hurts. So even just the physical component from constipation can be significant. Leads to decreased appetite and sometimes leads to weight loss. So that's something that, nutritional health in the setting of cancer, and especially when you're being treated, is extremely important. So we need to make sure that we're keeping that avenue open. And then social barriers. I have patients tell me that when their bowel patterns are irregular or they're constipated and now they're needing to take a bowel regimen, they don't know what's going to happen. So they don't want to go out. They don't want to be at the mall with their family and something unexpected happen, or they don't want to be at a restaurant. So again, that's very important to me as a clinician to try to make sure that our patients are maintaining as normal a quality of life and function as possible. So assessing for those issues are very important. I'm going to jump on the key message that Dr. Roeland shared, that prevention is key in this symptom as well, especially, as I mentioned, in the setting of opioids. If I prescribe any kind of opiates on a regular basis, basically my rule is if you need something every day, that you have to be on a bowel regimen. That should be started as soon as regular opioids are started. I have had several people who may only need a breakthrough pain medication a couple of times a week who feel that they can manage and prevent constipation with dietary measures. But my rule of thumb is if you take something every day, we need to be preventing constipation. Chemotherapy-induced constipation, again, that's fairly rare. But if that develops, making sure that we initiate a regimen as any first sign of change in bowel pattern or the stool. So making sure that you let your clinician know immediately. And then maintaining hydration and mobility are really the hallmarks for you at home, to make sure that as much as possible that you're staying hydrated with decaffeinated fluids, so making sure that you're having juices and water and teas that are decaffeinated, because any kind of caffeinated fluids tend to be more of a diuretic, so that can lead to a change in the bowel function as well. And then again, mobility. Even if it's small distances within your home, if someone's going through a period of time where they're feeling very weak, making sure that we're trying to maintain any kind of mobility and not staying still too long. So thinking about, again, just reiterating some treatments. We always like to try non-medication treatments as much as possible, especially with prevention. I'll harp again on mobility, making sure that you're regularly exercising, getting out of bed, making transfers. And then, if constipation begins to be a problem, I think it's extremely important to first look at what medications you're on for other issues. Looking at antidepressants, looking at supplements that you may be taking, looking at pain medications, and reviewing those with your medical team, because there could be a very easy rotation of any of those that would take away that side effect of constipation. So looking at any kind of root cause is very important. And then thinking about dietary modifications. Again, decaffeinated fluids, looking at fiber, so fresh fruit, vegetables, or fiber supplements. It is important, however, that if you're not adequately hydrated, that we're not adding fiber. So I will have some people who are not able to keep down a lot of fluids. They're really not eating very much, but they're also taking a fiber supplement, and that does not lead to a good outcome. If someone is taking fiber without the hydration, that can actually make the constipation worse. So making sure that you're staying hydrated, again, is very important. When we think about medications, again, treatment, prevention is key. What I will do typically as a prescriber is making sure that if you do have a high risk factor for becoming constipated related to medications or mobility issues, always starting with something mild and something fairly natural, which I tend to use the combination of a mild stool softener and a stimulant. I tend to lean toward the CINVs because what I hear from my patients is there's not the associated cramping with the stool softener and the stimulant level of the CINV products. And so those can be bought generic and over-the-counter or prescribed. And so I like to start patients out on that because it's quite gentle, and it can help us prevent the constipation. And then if it starts to become too much for someone, they can easily titrate or wean the medication. So if you start out taking it twice a day, you can easily back down to once a day or skip a day. I always tell people they really can't mess this up unless they just stop taking it completely. If that doesn't work, or if it's working but not well enough and you need to add something in addition or in substitution, typically my next step up is we'll go to the polyethylene glycol product. So you may have heard of Miralax or Glycolax. There's also generic formulations that you can get over the counter. And that's a stool softener that's a little stronger. And so people typically can get away with that once a day. And you add that to any kind of liquid. It really doesn't have much taste, and that tends to be very effective. Lactulose is another product that is prescription that can add much more kind of power to that bowel regimen, as well as magnesium hydroxide. So you may have heard of milk with magnesia. So that could be a next step up. If we still are not making progress, if there still tends to be a problem, someone's not responding to those medications, we can move to a little bit heftier of a regimen. The bisoprolol products, more of a stimulant. There is a risk or some side effects of cramping for some people, not everyone, but it's important that we know what's happening if you do take these medications. Magnesium citrate, so that's a kind of a liquid preparation that some people use that prior to procedures, but you can also use that for very severe constipation. Metoclopramide is a medication that was mentioned earlier also for nausea. Dr. Roeland discussed that that's more for that stomach mobility. And I always tell people it almost kind of helps your natural process of moving food through your gut. It really accentuates that process. So if someone is having nausea and constipation, I am also a big fan of adding that for symptom management. And then there is a medication that's fairly new in the last several years, probably close to 10 years, we've been exposed to methyl naltrexone, and that is a medication that typically is given by injection in the inpatient setting. I have not personally used it, been able to get it for too many people in the outpatient setting orally, but that is specifically indicated for opioid-induced constipation. So that's for some very severe symptoms that are not relieved by these other medications, a little milder. So what can you do? What are we asking of you to help us manage this for you and with you and help you prevent this? So tracking symptoms. I'm a big fan of patients logging their symptoms. So getting a blank calendar, and as we start to manage symptoms, that we log what happens each day, because it's very common to see people in the outpatient clinics and they say, I think 1 week it was working, 1 week it wasn't, and it's really hard to recall what happens on a day-to-day basis and what helps and what doesn't. So I really encourage you to track your symptoms, whether it's constipation, diarrhea, nausea, vomiting, and really help you and help us understand really what's happening. Again, I can't reiterate how, just like Dr. Roeland did, but share these problems with your medical team. We can't help you if we don't know what's going on. I find that a lot of people that I work with are embarrassed to talk about bowel issues, but this is very, very important. And if we don't address it early, if we miss the mark on preventing and we let it advance, we can end up in the hospital with much more hefty-duty complications. So I think it's very important to be open about it. Finding the regimen that works for you, because everyone that's listening today may be on a different regimen that works well for them. As I mentioned, I have a standard of what I go to as a clinician, but I also need to hear what works for each patient and how that's helping them. And just to remember that these issues may seem small in the big scheme of things of treating cancer and dealing with chemotherapy, but these issues that compromise quality of life are extremely important and valid. And as your medical team, we always want to make sure that we're honoring that and that we're hearing anything that could make your quality of life better. I'm going to turn it back over to Dr. Roeland, and we will talk a few minutes about the issue around diarrhea.
Thanks, Nikki. So we went from one extreme to another, and now we're talking about diarrhea. And this is becoming more and more common with the use of our immunotherapeutics. And so another important topic for people to consider, and we'll talk about some management strategies. So I'm sure everyone is aware, but this can lead to dehydration, dizziness, weakness, falls, which we really want to avoid and ensure patients are as independent as possible for as long as possible. Your oncologist is also worried that it may cause injury to your kidneys, which would actually prevent you from receiving full-dose chemotherapy. Very important point. And then can cause, when an issue for over a long period of time, poor absorption of oral medications and even weight loss or poor nutrition. So causes of diarrhea, everyone should be sure to communicate with their treating team if they experience diarrhea. Something that's very common is that infection can actually occur. And the most common infection is something called Clostridium difficile, or C. diff, which is normal bacteria of the gut that happens to be the one that can grow back the fastest after you have received antibiotics. And when the normal flora of the bowel is out of whack, the C. diff can grow and cause even worse worse diarrhea. So something for us all to be aware of, especially after receiving antibiotics or being hospitalized. Too much fiber or maybe even food intolerance can cause diarrhea. And people who may not be intolerant to milk products while on chemotherapy and having diarrhea, that can actually worsen your diarrhea, and we'll describe that a little bit more. I like to point out a very strange phenomena, which is in the setting of constipation, patients can actually experience overflow diarrhea. And I have a couple diagrams there to help people understand this. But basically, in the setting of severe constipation, what happens is the bacteria in the stool can actually liquefy, and just like water going around a dam can cause diarrhea. This usually happens after patients have been on pain medication for a long period of time and experience constipation over, say, a week to 10 days. So if you have severe constipation that is then followed by watery diarrhea, please ask your treating team about the possibility of overflow diarrhea, because in this setting, you would actually take a very aggressive bowel regimen to treat constipation, to treat diarrhea, which sounds very strange. It's usually diagnosed by the clinical history and by a simple x-ray. Withdrawal from opioids can cause diarrhea, and then of course our treatments, including radiation to the gut, chemotherapy, and immunotherapy. And I've listed here the risks associated with them. With our traditional chemotherapy, it's actually pretty mild, but with immunotherapy, it can go from mild to severe very quickly. So if you're receiving nivolumab or Opdivo or ipilimumab called Yervoy, and I failed to include pembrolizumab or Keytruda here, and you're experiencing diarrhea, this could actually be the symptom of a severe side effect called colitis, and your team must know, so be sure to call them. And then with our targeted agents like Tarceva, the chance of diarrhea is pretty low. With these newer agents that I described, nivolumab, pembrolizumab, and ipilimumab, this is a situation where we may need to consider a dose reduction if you continue to have a bunch of diarrhea, or a dose delay. And then in some instances, we will actually add a glucocorticoid or a steroid, such as prednisone or dexamethasone. There have been some studies about a steroid called budesonide, which is usually used to treat patients with chronic inflammatory diarrhea, such as Crohn's or ulcerative colitis. But in this situation, we have studied its use in controlling immunotherapy-induced diarrhea, and the data doesn't show that it works, unfortunately. So good idea, but actually it just doesn't work. General things, you gotta communicate. Yeah, I'm sure you're hearing some themes here. Maintain that hydration. Also protect the skin around that area. And just like babies, there are some skin protectants that you can put around that area, including zinc oxide. You want to treat infections. I've shown a picture here of stool samples. Sometimes you're asked to collect some stool and bring it in for evaluation. You want to hold your laxatives. The major and notable exception is overflow diarrhea. And then sometimes, as oncologists, we have to consider dose reduction or delay. So some tips. Everything that goes out of your body must equal what is coming in. So you got to get plenty of clear liquids, avoiding caffeine, and then milk products. The reason why I say milk products is what I've shown you to the right there is what we call a villi. These are little finger projections that line the small bowel and help absorb nutrients from everything you ingest. And there's the blood vessel there, and then the lacteal, which is the lymph vessel, which helps absorb. But the milk products are actually digested by an enzyme that resides in the very tip of that mini finger. And after lots of diarrhea, these villi are injured and lay flat, which really impairs your ability to digest milk products. So I typically encourage people to avoid milk products if they're having diarrhea until the diarrhea resolves. Other approaches include a real bland diet. And with anyone with kids out there, you're probably aware of something called the brat diet, which includes bananas, rice, applesauce, and toast. And then you want to avoid real greasy, fatty foods, smoothies with lots of kale in them, high fiber foods, gassy foods, and then any kind of herbal supplements that actually may be contributing to this as well. So medications, so if you are taking pain medicine for cancer-related pain, opioids actually slow down the motility of the bowels. But there is one over-the-counter opioid type drug called loperamide that's not absorbed outside of the GI tract. And that can be used to help slow down diarrhea after you've ruled out infectious causes. And I've included the instructions there, which are also located on the back of the box. Another option is Lamodal, which is also available over the counter. And again, those are the directions that are listed on the box. Chronic diarrhea medications, as Niki has pointed out, so sometimes we'll use bulking agents such as fiber or methylcellulose, which can actually help bulk stool after you've had chronic diarrhea for a long period of time. And then there's some alternative agents with which palliative care clinicians are aware of using, which include cholestyramine or octreotide. I put those for your reference if you've tried other things and they haven't worked, and you could share those with your treating team. So in summary, diarrhea has huge impacts on quality of life, and it's becoming more and more of an issue with the use of our new fancy immunotherapeutic drugs. Remember that overflow diarrhea, which is such a random thing, and that the actual cause is constipation. And then we reviewed general measures and over-the-counter medications that are available for you. So this leaves us a little time for questions and answers.
Yeah, and thank you both Niki and Dr. Roeland, just really terrific information. And hope folks will continue to post questions. Again, there's a little box on the side where you can, post your questions. We're going to start with this from Mary. And I'd love it if both of you could weigh in if you've got things to add. Does a very high fiber diet make Zofran cause constipation worse or better?
Well, we can share. I would just say that I think, again, what I find about the high fiber is that it has to go hand in hand with fluid intake. So that tends to be when it negatively impacts constipation. And so if, I guess I haven't had that direct question before, but it's kind of a 1 + 1 = 2. So if you are on a high fiber diet, maybe not as hydrated, and taking Zofran, and you're constipated, I would think we might need to think about either lowering the fiber a bit or rotating your anti-nausea medications.
Yeah, I totally agree with Niki. And in fact, I try to avoid fiber just given the number of variables that are thrown at patients as they're going through chemotherapy. And when I say that, I'm talking about supplemental fiber, so fiber capsules, unless instructed otherwise. Natural fiber, such as eating mangoes or peaches or something, I don't necessarily find to be an issue. But I would suggest that you stop the fiber and see how that goes for you while taking your Zofran. Okay,
great. Thank you. Another question, and this has to do, I think, with nausea, oral nausea drugs, obviously not with those that are given IV before chemotherapy. But how do I manage my nausea if I can't keep my pills down? And I think that's a great question for people taking even oral medications or other pills for other conditions they might have. If you have any tips on how they can keep pills down when they're experiencing nausea and vomiting, or I guess especially vomiting.
Yeah, so the first thing is that it sounds like with oral medications, usually patients experience chronic nausea. So this is nausea that you just kind of have as you're taking your oral chemotherapy over days. So we don't necessarily have a pre-medication strategy associated with that. But in general, what I would do is I would discuss with your treating team to consider taking a medication about an hour or 30 minutes before you take your oral chemotherapy, just to calm things down and so that you are less likely to experience nausea and vomiting. And usually the drug of choice in that setting for me is metoclopramide or Reglan, which works on dopamine and again has that added side effect of helping move the stomach. But if you're having any kind of diarrhea, we would avoid the use of that drug. And then I have used olanzapine or Zyprexa in this chronic setting with great efficacy. And so even we're now studying the use of that drug to be taken on a daily basis outside of kind of that 5-day chemotherapy window that we have studied in the IV setting. And I would specifically ask your oncologist if they're aware of olanzapine, and if not, if there's anyone at the institution that is, especially given that it has recently been published in the New England Journal of Medicine. Niki, you have anything to add?
No, I think that's a great answer. I think there are some sublingual options that we've tried. Ondansetron obviously comes sublingual. I found good success with using the lorazepam sublingual, but I have found just kind of through my nursing world that the 1 milligram tablets tend to dissolve better than the other doses. So people that aren't able to keep things down, that tends to help at least relieve the acute nausea without having to try to re-swallow a pill.
Okay, great answers. I think we have time for one more question, and this comes from Patricia. Regarding the overflow diarrhea, how do you know if this is the case and if you're impacted?
So there's two things. One, the clinical history. So if you had a time period where you were either on a medication that caused constipation or were taking a bunch of Imodium, which patients often do after some diarrhea and then end up getting constipated, there's a clinical scenario that's really important there. But when in doubt, I just simply get an X-ray and ask the radiologist to quantify how much stool they see in the colon. And frequently that is revealing of an issue. And then how I approach that typically is that I prescribe usually Miralax, which is a white powder which is dissolved in water or juice. And I ask patients to take that every 2 hours until they have massive diarrhea, just to clean themselves out, much like you would for a colonoscopy preparation. But again, all that should be done under the guidance and advice of your treating medical team.
Okay, thank you so much. We do have some other questions, and I would just want everyone to know that we will be getting in touch with them to get those questions answered, and I'll be involving Niki and Dr. Roeland as necessary. So thank you for your questions. Just know that they'll be answered. But our time is up for now. So we're going to have Niki just go through and give us a quick wrap-up, and then I'll have some final words. So go ahead, Niki.
Thank you, Maureen. So thank you for your attention today. I think there's a lot of information here, and I think that it can benefit a great many of people. I think that what you heard us say many, many times was how important it is to talk to your medical team about what's going on. We honor your quality of life and what's making life easy for you and difficult for you, and so it's so important that you share what's going on. I've heard from patients that they're afraid to tell about their symptoms because they don't want it to interfere with their treatment course, and we don't want you to be afraid of that, because we can treat these symptoms and we can help you with them. And if we know, the earlier we know, the less impact it can have on your treatment. I think that I share Dr. Roeland's affection for olanzapine. That's become our favorite around my clinic in Charlotte. And so we have seen extreme success with that with very little side effects. So I reiterate his urge to you to talk to your team about that option if that's appropriate for you. And then just to reiterate again that prevention is key, whether it's constipation, whether it's nausea. It's one of those things we don't want to wait until it's severe and meet you on the hospital side. We want to make sure that we can prevent these issues so that you can get your treatment, you can feel good, you can stay strong and functional and very healthy with your nutrition. And so with all of these things said, that will allow you a much easier course with your treatment. So we appreciate your time and your attention, and I look forward to seeing the other questions.
Yes, and I echo Niki's expression. We really want to thank all of you for joining us today, and we hope it's been helpful. Just know that this and the other coping series videos are posted to the Lung Cancer Alliance YouTube channel, and that Lung Cancer Alliance is here to answer questions about digestive problems from lung cancer or anything else related to the disease. You can just call our helpline at 1-800-298-2436 or email us at support@lungcanceralliance.org. If you have questions specific to this webinar or the coping series, please don't hesitate to ask me directly. So we'd like to give a special thanks to Niki Koesel and Dr. Eric Roeland for helping us learn to prevent and manage digestive problems, and for their dedication to improving the lives of people with cancer. We hope that you'll join us in July for the next installment of our coping series, Managing Anxiety, and we'll have more details on that soon. Thank you all for your attention. Bye-bye.